Hi, my name is Dr. Tim Yu. I'd like to share this interesting case I completed during my orthodontic residency at the University of the Pacific Arthur A. Degoni School of Dentistry with my former co-residents, Dr. Jared Little and Dr. Christine Stepanek, under the guidance of my clinic director and mentor, Dr. Joorok. The patient presented to the University of Pacific Orthodontic Clinic when she was 13 years, 1 month, with a chief complaint of, "My top and bottom front teeth do not touch." She is in good general health with no contributing medical history. She has had no previous orthodontic treatment and denies any history of oral habits. Pre-treatment facial photographs reveal the patient has a straight profile with an obtuse nasolabial angle. From the frontal view, her face is grossly symmetric with an increased lower facial third. She has a moderate mentalis strain seen at rest. Her lower midline is coincident with the face, and the upper midline is half a millimeter to the left of her facial midline. Upon animation, she appears to have adequate incisor show and excess buccal corridors. The intraoral photographs reveal the patient is in her full permanent dentition and has good oral hygiene. She has a class 1 molar relationship bilaterally. A moderate to severe anterior and posterior open bite is seen. The study casts reveal that she has a mild positive overjet measured at the left maxillary and mandibular central incisor. She has a severe crowding on the tapered maxillary arch with the upper left 2 in lingual version and mild crowding in the anterior dentition on the mandibular arch. The initial panoramic radiograph reveals no caries or gross pathology. The TMJ anatomy is within normal limits and the 8s are developing in all 4 quadrants. The lateral cephalometric analysis indicates a class 3 sagittal relationship and a hyperdivergent growth pattern. The maxillary incisor displayed a slightly upright incisor inclination, and the mandibular incisor inclination is within normal limits. There were 3 treatment options that were presented to the patient. First, orthognathic surgery, a segmental 3-piece Lefort 1 osteotomy to advance, posteriorly impact, and expand the maxilla, and a minor mandibular bilateral sagittal split osteotomy setback to correct the skeletal class 3 relationship. Second, comprehensive non-extraction orthodontic treatment with fixed appliance. Use a microimplant assisted rapid maxillary expansion with face mask to correct the class 3, followed by posterior intrusion with skeletal anchorage and autorotation of the mandible to close the open bite. Third, comprehensive non-extraction with Invisalign clear aligners and ample mandibular interproximal reduction and mandibular incisor extrusion. If you are interested in how this case was treated, please go to the 2021 summer issue of the PCSO Bulletin. Thank you.